So I'm going to talk about BodyVision or LungVision's technology, which is a novel augmented fluoroscopic platform that Kyle introduced with a major overview of the trial. Now I'm going to talk specifically about fluoroscopic LungVision navigational bronchoscopy with cross-correlation between cone beam CT bronchoscopy and radial EBUS. I have a number of disclosures. I'm a little bit jealous after seeing Kyle's disclosure list. But we all know that peripheral lung biopsies or lung nodule biopsies are challenging, and there's an entire variety of reasons as to why it's challenging. We know that if we can biopsy these lung lesions that are difficult to see or difficult to get, we can potentially increase the survival rate of lung cancer. And early detection relies on the early diagnosis of these peripheral lung lesions. Now, biopsies of lung nodules can be complex due to the anatomy of the bronchial tree, the size of the lesion, the location of the lesion, respiratory motion, even cardiac oscillations. And so right now, there's no real support for real-time visualization from a pathway perspective and from an augmented image perspective currently on the market. What LungVision does, and I want to talk a little bit more about this, is that it's separate from a standard GPS navigational bronchoscopy because it uses artificial intelligence. And so it's different and novel in that way, is that as the computer program is learning, it's also learning from patient to patient in a process what we call deep neuronal learning is allowed to be able to learn the airway. So it learns aspects as to this is the right upper lobe. So the first 5 or 10 times that the software program will not recognize it, but after 400 patients that have been done, it knows what the right upper lobe is, what the right middle lobe is, what the airways are, and tries to account for tissue distortion from the catheter that has radiopike markers in it. And so it is a completely different system from what you're probably used to seeing. So, but it has some common traits with other systems. So you use a pre-planning CT scan, also 1 millimeter cuts. You put it through a planning software. Then you utilize the LungVision device, and then the image then gets placed onto an augmented screen with the pathways and the nodule. The purpose of this particular sub-study was we wanted to confirm whether or not LungVision and its augmented technology is actually accurate when you compare it to other modalities, including cone beam CT bronchoscopy and radial EBUS. So patients had their scans imported into the software. We mark the nodule, mark the pathway, and then we do a registration process where we place the catheter, which has the radiopake markers, through segmented airways that are predetermined and line up the CT scans so we can minimize CT to body divergence. After that, we then navigate as you normally would navigate with any kind of navigation software, but this time using the fluoroscopic-based images as the main modality of navigation. Then we then confirmed first with radial probe. So we took a radial probe 1.7 the Olympus 17S probe, passed it through the bronchoscope working channel, through the extended working channel of the BodyVision catheter, and then visualized whether or not we were able to see the lesion, and then turned around and then placed a needle or an instrument, a device, tape that instrument, because we're not allowed to hold a scope or the instrument while a cone beam CT scan is being performed. So we lock the scope, lock the tools into place, and then we perform a cone beam spin, which then will allow us to confirm whether or not we're actually in the target or not. And this is really a powerful technology if you think about it, because we've been living in for the last decade in this virtual world, is that we always think that we may be in the lesion or there may be other factors, but this is a way of saying both with a technology that's familiar with us with radial probe and with a novel technology of cone beam CT has been pioneered by Dr. Pritchett, is a way for us to be able to look at these lesions real time, and then we would perform biopsies. So it's a small number of patients, 13 patients. The median size was 20 millimeters, predominantly female, of course smokers, and you can see that there was a pretty even split between the sizes, about half and half. And as with most lung nodules that we're biopsying, we're doing it for the purposes of malignancy, and the upper lobes are often the case where we go after the lesions the most. Now, looking at this slide, I'm going to walk you through 3 different cases to kind of give you an idea of what the procedural flow would be like. This is a lesion that's kind of hard to see, but the lesion is located at a bifurcation point next to the airway. And then these are the multiple airways. All the airways that we are not interested in are in green, and the pink pathway is where we want to go. Here, when we actually navigating, there are tungsten beads that are set up in a three-dimensional format on a plate underneath the patient. And then what we do is we perform the pathway planning, and it projects the image onto the fluoroscopic screen that synthesizes it and tells you where it is, much like in the video that Dr. Hogarth had shown us. And then you can see the actual lesion traced out in yellow, and you'll see blue pathways where we want to avoid, and the target area, which is in pink. This is a difficult airway, so we had poor r-EBUS verification, but with cone beam CT verification, we were able to see that the needle was actually in the lesion. This is another example of a right upper lobe lung lesion, and here you can see the fluoroscopic or r-EBUS images. And going through this is another one which is a part ground glass, part solid lesion or subsolid lesion. You can see that we're able to identify with the appropriate pathway that will lead to a diagnosis. We navigate it out. Here you can see the catheter kind of following the course. So you can see obviously there are some limitations. There is some tissue distortion that occurs with the catheter. So we have to keep that in mind. But overall, it's on target. We did a r-EBUS verification. Remember, this is not a solid concentric view that we would hope for with a solid lesion. This is a part ground glass lesion. And typically my approach to ground glass lesions with a peripheral probe is the first pass or two that you have with your radial probe, and then you're probably obscuring your view and you become less reliable on the peripheral probe because of hemorrhage and tissue distortion, atelectasis, etc. So after that, we perform cone beam verification. So if you can make this out, and I'm going to trace this out for you, here is where BodyVision was saying that the lesion was, the center of the target lesion, and the augmented image on both being overlaid at the exact same time. And these are some fancy images that we were able to provide with the cone beam, where you can see where we subtract out the soft tissue, we segment out the tumor, and then we're able to show that the lesion is actually, the catheter and the tool is actually what we call tool and lesion conformation. Another example of a left lower lobe lesion. I'm trying not to show you just easy lesions, but that we had some difficult lesions as well. It's hard in such a small number of patients to make it extrapolate that this is going to be viable for every single case, but I wanted to show you lesions in the right upper lobe and the left lower lobe. And I remember I have a unique practice where I get sent cases, and every pulmonologist and thoracic surgeon is allowed to post onto my schedule as long as I see the CT scan. I don't know what I was thinking this day, but I apparently went after this lung lesion that's close to the diaphragm midline. And I think the reason for this is that no interventional radiologist was interested, and no thoracic surgeon was interested. And so as a result, we drive down the predicted pathway. Here you can see where BodyVision was saying that the lesion is in the augmented view. I didn't make the spherical, I tried to cut away the diaphragm so I didn't cause a pneumothorax. We performed r-EBUS verification, and then here you can kind of make out on this particular cut the lesion with the needle going into it, and some augmented images that are shown here. This is another left upper lobe lung lesion. This is also a 16 millimeter lung lesion located in the periphery of the lung. All appropriate cases for navigational bronchoscopy, drive out to the lung lesion. Here's where the BodyVision predicted that the lesion should be and would be. Here's the tracing, so the lesion actually grew in size to some degree. And here you can see r-EBUS verification. This is a video. This video is showing, just before I started, the bronchoscope, the catheter provided by BodyVision that has radiopaque markers that are in an interval, and then a needle coming out, and this is the airway tumor being segmented with using Siemens software. So this gives you an idea of what this level of verification allows the provider to be able to say, does LungVision actually localize the lesion? And here we drove through the pathway, parked it, r-EBUSed it, took a CT scan. So we did 13 patients. Average procedure time was 51 minutes. We had 13 cases that were localized with LungVision, confirmed with both r-EBUS and CBCT imaging. We had one patient that was a ground glass lesion, very difficult for me to get to, and we did not have tool and lesion confirmation nor r-EBUS confirmation. And so I'll open it up for, so the last slide is 92% localization success, high accuracy, capable of real-time localization, understanding that there's going to be respiratory motion. Not every white circle that the cone beam predicted is completely 100% overlaid with the predicted augmented image, but they're very close. And then we can see that there's tissue motion tracking, which is something that's not available. And then we can see image guided transbronchial lung biopsies. This is important because as this software is being developed, the idea is the artificial intelligence component of it will continue to improve as the catheters improve, the research and the software development improves. I'll open it up for questions.